to something, well, it feels like it should be straightforward managing pain,
Hmm.
but actually, our sources show there are some really specific, very powerful principles involved,
Hmm.
especially for tough situations like cancer pain.
Right.
You might think you've got a handle on it, but we're hoping to give you a bit of a shortcut today to really get those nuances that make pain control effective.
Exactly. We've looked at quite a bit of material on cancer pain management, and we've tried to pull out the real core insights. The goal really is to, move past the common stuff and show you what truly effective pain control looks like.
Okay, let's unpack this then. When you're dealing with pain, where do you even start? Our sources seem really clear on the first step, the most foundational one. It might sound simple.
Yeah, it sounds simple, but it's absolutely paramount, and maybe sometimes underestimated. It's a thorough assessment.
Assessment? Oh,
Before you even think about treatment, you have to really understand the pain. What kind is it? How intense? Where is it? What helps? What makes it worse?
yeah.
I mean, that detailed picture, it's the bedrock.
Right. Otherwise, you're just guessing.
You're building on shaky ground.
Yeah.
Yeah.
So once you have that picture, that assessment, what's next? How do we actually deliver the relief? The sources talk about a preferred way to give medication.
Yes, the oral route taking medication by mouth is preferred whenever it's possible. Simple, convenient. But here's where it gets interesting, and there's a really key correction we need to talk about regarding morphine.
Morphine potency. I think I know this one. The oral versus injection ratio. Isn't it usually taught as 6 to 1?
That's exactly it. That 6.1 ratio,
Yeah.
oral to parenteral, it's everywhere. But clinical experience, especially when morphine is used long-term, day in, day out,
Mm-hmm.
the actual ratio observed is much closer to 3.1.
3 to 1. Wow, that's half. That's a huge difference.
It is. And it's not just academic. If you stick rigidly to that old 6.1, you could seriously undertreat someone's pain. Or, overtreat if you're not careful adjusting doses. It's a critical detail for getting the dose right.
That really is crucial. Okay, so route established, potency ratios clarified.
Hmm.
What about the actual dose? And maybe even more important, the timing.
Well, first, you absolutely have to match the drug and the dose to the level of pain the patient reports. Tailoring it is key.
Makes sense.
But here's the golden rule for persistent, severe pain. Medication needs to be given on a schedule, around the clock, not just take it if you need it.
Not PRN or as needed. Why is that so important?
Think about it.
Yeah.
It's always, always easier to prevent pain from coming back than it is to knock it down once it's already flared up. You want to stay ahead of it. It's proactive control.
Proactive, not reactive. I like that. Okay, so if everything's scheduled, where does that leave the as needed or PRN doses? Do they have a role?
Oh, absolutely. Excellent question. PRN dosing is specifically for breakthrough pain.
Breakthrough, like pain that pops up despite the regular schedule.
Exactly, that unexpected spike. And for that, you should always have a short-acting, immediate-release opioid available alongside the long-acting scheduled one. This is
Yeah.
your rapid response plan for those flares.
Okay, so it sounds like this isn't a set it and forget it kind of thing. It needs watching.
Constant vigilance, yes. You need frequent reevaluation, especially when you first start therapy or make changes. How's the pain? How's the relief?
And how do you know when the plan isn't working quite right? When to adjust?
There's a key indicator. If someone needs more than just two of those as-needed breakthrough doses in a 24-hour period,
Uh-huh.
that's a clear sign. The main scheduled regimen isn't cutting it. It needs modification. And here's another important point. Before you jump to a different drug, try to maximize the dose and the schedule of the current one first. See if you can get it working better.
Got it. Optimize what you have before switching. Now, is it all just about the main painkiller, the opioid usually, or is there more to it? It's definitely more holistic than that. You absolutely need to think about managing side effects from the opioid itself. Like constipation, it's incredibly common, almost expected, so you plan for it with other meds.
Right. Manage the side effects proactively, too.
Exactly. And then there are adjuvant analgesics. These aren't primary painkillers, but they help boost control. Things like certain antidepressants or anticonvulsants can be really effective for specific pain types.
Okay.
And don't forget, non-drug approaches, physical therapy, psychological support, they're vital parts of the overall plan.
So putting it all together, what are we actually aiming for? The sources mentioned something called the 5 A's as goals.
Yeah, it's a great framework. Really helps keep track of the overall goals. The 5 A's are, first, optimize analgesia, get the pain down.
Okay.
Second, optimize activities of daily living, help the person function, live their life. Third, minimize adverse effects, keep side effects low.
Makes sense. Fourth, avoid aberrant drug taking. Ensure safe use, prevent misuse. And fifth, address. Affect the relationship between pain and mood. Recognize that psychological impact.
Analgesia, activities, adverse effects, aberrant drug taking, and affect. The 5 A's. That's a helpful checklist.
It really is.
And the impact here, it's not just about feeling better, is it? Our sources suggest this connects to much bigger things, quality of life even, survival.
Absolutely. Effective pain control isn't just comfort. It enables people to eat better, sleep better, be more active, engage in treatment. It has systemic benefits. It really can impact overall outcomes.
Wow. And what about really severe acute pain, like a crisis?
Yeah, for those situations, the sources suggest thinking about admission to a hospital or maybe an inpatient hospice setting, somewhere you can get really intensive management quickly. And of course, always look at treating the underlying cause if possible, like using specific cancer therapies for tumor pain. That can be the most effective pain relief sometimes.
So it seems what starts as simple principles really unfolds into this quite nuanced, very practical, and profoundly important approach to care.
It really does. These aren't just abstract guidelines. They're strategies that genuinely improve people's lives.
It really highlights the difference effective management can make.
Mm-hmm.
Yeah.
And maybe the final thought here is, what if we shifted how we think about this? Not just see pain management as fixing a problem once, but as this dynamic, ongoing thing, a continuous process of checking in, adjusting, supporting the whole person.
Always reassessing, always adapting.
Exactly. Truly effective care. It's proactive, it's multifaceted, and it's always looking at the bigger picture of well-being, not just the pain score.